Hello everyone, welcome back to Hot Seat Season 3. It's Omid Moghaddas from Tehran, and once again, I'm so grateful and honored to have the chance to share this platform with all of you, with great educators, leaders, influencers from around the world in the field of perio and implant who are kind enough to accept the invitation and share their experience, their skills, their knowledge with all of you and help us become better and better in our knowledge, in our practice, in our skills, especially during these times that we have limited access to the congresses, symposiums, or courses. And today, our dear friend, Dr. Naheed Mohamed, is here with me from Canada. Hello, Dr. Naheed, and welcome to Hot Seat.
Hi, thank you. Thank you for having me.
Thank you. It's our pleasure. So before we start, I have to say we try to cover many different aspects in implant dentistry and periodontics during last 2 seasons. And today we have a very exciting topic because we didn't have that much talk on that. And that is the use of digital technology and 3D printers, not only by saying about guided implant surgery, but also in different aspects in implantology and how 3D printing and digital technology can help us improving our techniques, improving our outcome for the patients. So before we start, I would like to have a very short CV of Dr. Mohamed for all of you, and then we will start the presentation, and for sure, at the end, we will have a discussion on that. Dr. Naheed Mohamed is a graduate with DMD degree from Boston University Goldman School of Dental Medicine, also specialized in periodontics and implant surgery from Case Western Reserve University and University Hospitals in Cleveland. He is also Canadian board certified periodontist, diplomate of American Academy of Perio, and implant clinical career more than 10 years. He is also a member of Ontario Dental Association, American Academy of Periodontology, and Academy of Microscope Enhanced Dentistry. His particular interest is in minimally invasive approaches to surgery, and he is an expert in dental implant and related site development surgery through bone augmentation and reconstruction. Once again, I'm so happy to have you, my friend, and we are ready for your beautiful presentation.
Okay, guys, let me just share my screen here. Oh, you know what? Oh, yeah, I'm going to discuss digital planning for implant-related procedures and implantology in general. And then also I'll show a few cases of just I have a case of crown lengthening as well. Now, over time, I've started becoming more interested in digital planning and using technology to improve diagnosis, improve your treatment planning, and as well as improving your not only the procedure, but also the results. And, digital planning allows you to virtually complete the entire surgery without even, doing anything. So you already sort of know certain aspects that you need, or complications or difficult areas that you may need to address prior to even doing the surgery. And so how I sort of came about my sort of journey into digital planning and using 3D printing is, I was actually influenced by orthognathic surgery. A lot of orthognathic surgery, they do digital planning for their jaw surgery. Now, when I looked into that, I thought, the concept is there. Why can't we use this for bone augmentation? And after doing further research, I realized that the digital planning that the oral surgeons use for orthognathic surgery is usually through a company. It's actually quite expensive. The system and the planning case costs almost $1,000 or a few $1,000s to do it. So it wasn't feasible to use those companies. So I decided to just learn more about digital dentistry, and we sort of modified. I've been influenced by some of our pioneers in digital surgery, such as Scott Gans, like you had mentioned. Luca Di Stavola had sort of influenced me with his guided bone graft surgery. So all this sort of brought me into, or planning it and sort of influencing my journey into digital dentistry. So I'll show you basically what I've basically designed, and I do this for a lot of my cases, is whenever I have a complex augmentation case, I virtually plan the surgery. And by virtually planning it, we have to collect some data. So what we do is we collect CBCT data, which will give us information about the bone volume. I do an intraoral scan, which gives us information about the soft tissues in the teeth. And then sometimes nowadays we could even introduce facial scanning for aesthetic areas. So you can sort of overlay all these together, and now you have a virtual model of the patient. And through that, and through CAD/CAM software, you can virtually complete the surgery. So I'll show, today I'm going to present a few cases just to explain this concept. And then we'll talk about what the future is going to be like. I think from 3D printing, we're going to go into now dynamic navigation and augmented reality. So this is the future. So let's start off with our case. So this is a case, I'm just going to show the planning of this case. This patient actually, I'm currently going to be seeing, she's coming from the US to see me, and the borders are closed. So we can't complete her surgery yet, but we did this planning with her dentist and her virtually so that she understands the concept of what's going on. So this is a patient had I think 2 surgeries already. Both were failures, or they just didn't get enough bone. And what happened is through the failures, she ended up with having less bone than she initially begun with. So now she was a little bit frustrated, and she wanted to make sure that she can get a result that will be predictable, and she can have teeth, because she's been edentulous for a long time. So what I do here is, you can see we've overlaid the intraoral scan in blue, as well as the CBCT software, which will give us our bone model. Now, this is all brought into sort of digital planning and CAD/CAM software through segmentation. So for those of you who don't know, when you take raw data, whether it's DICOM data, you can actually virtually segment it to create 3D models. And that's what has been done here. So we've taken our DICOM data and segmented it to create these 3D models. And so here we have our pre-op, bone and soft tissue. So here we have basically a virtual model of the patient's jaw. Now, so here's the actual edentulous jaw. So you can see here, quite a large defect. The mental foramen is right there. It's almost at the crest. And literally there's no volume for implants at this point. Okay, so what I do now is, we know that implants themselves are prosthetically referenced. We place implants based on where we want the teeth. So in the same sense and the same concept, we build bone where we want implants. So it all is interconnected to really teeth, because a patient doesn't come to you for implants, they come to you for teeth. So everything starts to be built backwards. So from here, we start off with our ridge. So this is what we have to start with. Now this all is now planned digitally. So from the ridge and from the intraoral scan, we do a digital wax up. So we basically start backwards. I start with the crowns in the ideal position. And this is worked up with the prosthodontist or the restorative dentist. Because I'm a periodontist, I don't really do the restorative work. So this is done with them in conjunction. Once we have the teeth in the ideal positions, then we look at the soft tissue and the ridge contour, which is shown in the pink. And then we work backwards. Okay, this is just another view. So you can see the alignment, everything is all digitally. Now, based on where we have the teeth, we are now going to decide where the ideal implants are placed. So this is just an occlusal view showing that everything is done, planned correctly. And these are just different views because you want to make sure that everything fits, virtually if anything is off with the initial crowns, and then all the planning is off. So you have to get this part right, and everything sort of goes downstream. So based on, let me just show this. So this is our wax up, or digital wax up. So from here now, we reference our implants. So the next slide shows, so I can, because this is digital, we can sort of remove the layers on the computer. So now we remove the layers of the soft tissue and the ridge volume, and now I show the crowns and the implants. So here, based on where the crowns are, I can see already how much deficiency there is with regards to bone volume required. So based on now where the implants are, we now create a digital bone graft. So now based on this, I know how much bone is required in order for us to reconstruct this patient. This is just different views. So you can see it's quite a large defect. We have to fill in, vertically as well as a little bit of horizontally, but majority of this reconstruction is in a vertical dimension. And so we need a good amount of vertical volume. So when I have it like this, I can move it around virtually. We can also 3D print this. So I can 3D print the pre-existing pre-op model, as well as 3D printing this rendered bone graft volume. And you can align them and you can kind of look at it in your hand. Sometimes 3D printing it in your hand, the model itself can be used to help with your surgery, as well as looking at it and deciding what's the best way I can get this amount of volume. Now, in this patient, you can see here, a lot of volume missing. You can see from the buccal, the occlusal, and the lingual views, there's a huge amount of vertical volume missing. So it's quite a bit of bone deficiency. So this is now our bone volume. So I usually will remove this and you can actually see the bone graft itself digitally. And you can see this, how I've shown it in different views. Now, based on the different views, I see where the volume is needed. And from here, I can diagnose or at least treatment plan my case. So this helps, sometimes, as you do a lot of these, I can virtually kind of just do this in my head, but it helps initially with more complex cases. I still do this with more complex cases because when I 3D print this, I can use it to choose my screw sizes. I can decide if I want to use a microplate, if I'm using a tenting technique, if I'm going to be using a titanium reinforced PTFE membrane. All of this can be measured and modeled and adjusted and trimmed, pre-op based on the 3D printed model. So this is what my virtual surgical planning entails. So based on this concept, I can now plan my case. So something like this, we would have to either do it with, like, if we look at the defect here, I would have to probably look at this defect. Now, she was coming from overseas. And so initially I thought, I could do a titanium reinforced PTFE membrane, but then I kind of took a step back. I said, I have to take into consideration the fact that she's going to be flying back and forth from the US. So if there's a problem, especially with titanium reinforced membranes, there's exposures and risk of infections that are more common. So I decided that I wouldn't go that way. We actually plan to use similar to Shukroon's approach where he uses the screw fast system. So we were going to use a titanium plate to go from the interproximal peaks of bone from distal of the canine all the way to the ridge, and then using tenting screws. And we're going to use a sticky bone approach. So we're going to basically build a tented space for the volume using pins and plates, and then use sticky bone with a resorbable collagen membrane that was secured tacked. So this was the best way I could get the volume with the least amount of post-operative complications and risks because of the fact that she was traveling. So based on all these concepts and the view, I'm able to plan the case. Okay, so this also can be done with bone plates and core plates, but she didn't have much bone to work with. And I'm not as talented as some of our surgeons like Frank and Luca there. They can take bone from anywhere and make it work. So this is the concept of 3D plan. Now I'll show a few cases just showing the execution of this basic concept. So I'm showing a digitally planned aesthetic crown lengthening case because it just shows that it's not only implantology related, anything that requires surgery in the mouth can be done digitally. So here's our case. Okay, patient came in. Actually, oh, you know what? Sorry, this is it. So this is our case. Patient had existing crowns. You can see the smile is off. She wasn't happy with it. She had a high smile line, but she wasn't too concerned about the smile line. We had also offered to do a lip repositioning procedure or Botox to help with that, but she said, no, it's fine. Let's just do the crowns. So this is the guide that we made. So this guide was a combination of a crown lengthening guide as well as implant placement guide. So she had an edentulous 2-4. You can see here in the video. So this is our initial intraoral scan with her CBCT scan. So we sort of overlaid the wax up. So we made a wax up for her crowns. We overlaid the wax up off of this. And then based on the wax up and her pre-existing condition, we designed the surgical guide. The surgical guide also included the implant placement guide. So it's a combination guide of crown lengthening and implant placement. And this is software that was made from my radiologist. So he's sort of designed the software. He's still working on it. So it's, if anyone asks, unfortunately, it's not available yet. But through this, he's made the guide, which will include the crown lengthening. So you can see the lower level of the crown lengthening guide will basically tell me where to contour or do the gingivectomy. And the upper portion is where we have to do the ostectomy to the bone removal. So the guide sort of has two levels to control both bone removal and soft tissue removal, as well as the implant placement. And so through this digital planning, we can now execute the case. So here's our case. So here's the guide in place. You can see if you look here. So this area will guide our soft tissue removal, and then we do sort of a biologic with 3 mm amount of the top level here. And so the surgical guide here is where we would adjust the bone crest to. So we use the guide, we trim the soft tissue. I lift the flap up, and now I will adjust the bone to the upper portion, or the more apical portion of the guide. So through this, the guide is controlling both parts, both bone and soft tissue removal. Here's our bone removal is completed. The guided implant placement is done here. And then the area suture. With these aesthetic crown lengthening cases, I tend to tie my suture knots on the palatal. So the patient leaves, without a bunch of proline suture knots showing on the facial. These are sort of vertical mattress sutures that position the tissue back to where we'd like. They come back after the healing. We do a little bit of minor adjustments in the contour if required. And here's the final result. So remember, we did crowns. There's an implant crown as well. The 2-4 is the implant crown. So all of this is all guided and controlled digitally. And so it makes, communication between what the dentist wants us to do, what the patient expects. So all of this is sort of streamlined. So there's less guesswork. So the digital planning allows you to complete everything more accurately with better communication between all the levels of the restorative, the patient, and the surgeon. Here's just a view. After we finish the crown, this just shows the premolar, which was the implant crown right here, which is, we did some augmentation and placement of the implant as well. After we had completed this, she was happy. She didn't want to do anything with her lip repositioning. She's like, no, I love it. She was fine with it. So this is the final result. So in the end, the patient is happy. We completed it through a digitally planned approach. Here's another case. So this case here is a vertical ridge augmentation. So this case actually had multiple layers, and it's actually a really cool case because it involves doing a vertical augmentation. It involves doing a sinus lift, avoiding the artery in the sinus wall, as well as using a 3D printed model to complete the bone augmentation. So based on the results, this is what we're looking at. So you can see there's adequate keratinized tissue. We're not worried about that. It's just a large vertical defect. This is my CT scan. You can see based on the CT scan, if you look, we have basically a large vertical defect here. We have a pneumatized sinus, so we'll require a sinus lift. And then we segmented the actual artery. So you can see the artery in the wall. Now, based on this, when we made so what we decided to do is, I wanted to be able to complete the vertical augmentation, complete the augmentation apically through the sinus lift, and then coronally at the ridge through a vertical ridge augmentation. So we had to sort of augment in both directions to recreate the ridge for ideal implant placement. The CT analysis also showed that we did have an artery in the sinus wall. Now it was not too large, but it was something that we could have managed. But we decided, since we're doing this digitally, we plan to create a surgical guide that would allow me to create my sinus window and avoid the actual artery. So this is just the DICOM, the software for the CT scan, just showing the segmentation of the artery. So now all of this has to be translated into something that we can use surgically. Here's our analysis with regards to our surgical guide. You can see here we have our implant. This is just a planned positions of the implant. And if you see in the white outline is our surgical guide. Now the surgical guide is created to make our implant placement, but as well, it does the sinus window. So you can see where that little arm that extends upwards shows the two little openings. Those two little openings are basically two little windows that will avoid the actual sinus. So this is our, sorry, just skip this step here. So this is our ridge. Again, this is based off the CT scan data. So we've sort of used segmentation to bring that DICOM data that you just saw previously into a 3D model. Here we've segmented the ridge. And based on this, I've created the volume, or the digital plan for the volume that I need off from the ridge. So we have bone volume that requires augmentation in the sinus, and then bone volume that requires augmentation off of the ridge. So based on this, this is our required bone graft volume that we need to reconstruct. So based on this, I now take those 3D models and we 3D print the model. So the model here now is used for surgical applications, meaning that I use this to plan my surgery. You can see here, it's an occlusal view, both from the sinus and from the ridge. And so using these models, I now can plan not only the shape of my membrane, but we're going to be using the augmentation to create a microplate. So here is the sinus window guide. So you can see here in the guide, we not only have, now it's tooth-borne, so that means that it's actually very accurate because it's not sitting on a segmented ridge, it's sitting on the teeth. So there's good stability and accuracy with it. We have our pilot drills for the implant placement. And then here we have basically two windows. Now this line here in the actual guide is where the artery runs. So by making my windows in two little spots, I'm avoiding the artery that runs through the wall. And this is again made very easy. There's no guesswork because literally I just pop in the guide and I make my windows. So here's our site. We expose the ridge. You can see the vertical defect there. You can see here now we have our guide in place. We make our two windows based on the guide's positioning and plannings. And then we lift the membrane, leaving this little bridge of bone where the artery sits. Membrane is lifted, the sinus is grafted. So now we've grafted vertically up in the sinus. Now the next step would be to build the ridge coronally with the vertical augmentation. So this is where the 3D model, the 3D printed model comes in handy. So based on this, what we decided or planned to do is to create some sort of support for our vertical augmentation. Now, because the sinus floor is very thin, I didn't want to use tenting screws because I thought they may loosen because there wasn't much bone to hold it. So I decided on a microplate. So the 3D model was used to trim and adjust the microplate to the right dimensions and allow us to basically tent our space for the vertical augmentation. So microplate is then adjusted off the model and then inserted into the site with two micro screws that holds it in place. And then the same model is used to trim and adjust my collagen membrane. So this makes things easier. You know, for those of you who do surgery, you know, sometimes it's a pain to try to trim a membrane, especially if it gets soaked in blood, then it just becomes like wet tissue paper. It's hard to adjust. So if you can do this on the model and it just fits in perfectly in the mouth, it makes your life much, much easier. So it not only increases the efficiency of the surgery, it reduces the surgical time, and it gives you less stress for the surgery. So all of these are benefits for the planning and the use of the 3D printed models. So here's our trimmed membrane. The trimmed membrane is tacked on the palatal side. We filled the entire void with allograft bone. And the allograft bone is basically filled to the height of where the microplate is. The membrane is then tucked around and over onto the buccal. You see the two bone tacks, bone pins, holding membrane in place. The flap is sutured. And now we just give it about 6 months. We see the site, this is at 6 months. We go in and re-enter, and you can see the amount of bone augmentation. So this is something, when you look at the case, you have a sinus, you have an artery, you have vertical augmentation on the ridge. It's made very easy and very predictable through the use of digital planning. So this is where we started, and this is where we end. So it's something that, you know, again, we took a complex case and simplified it, and through the planning, it became quite easy and quite predictable. And you can see we have a good amount of bone volume, It's nice, healthy, vital bone. This is allograft bone, so it turns over really nicely, and you can see the quality of the bone there. And then our implants are placed. So we actually kept the guide. We used it to place the implants later on. I didn't want to place the implants all together because sometimes it's just, as I say, too many miracles at one time. I'm able to now place the implants in ideal amount of bone. And there we go. So that's this case. So you can see how the planning allowed me to simplify and do the quiz quite easily, which otherwise would have been, a little bit more trickier. Now, it's not to say that you can't do it without planning. It just makes your life easier. Here's another case. This is a horizontal ridge augmentation case. Evaluating the tissue, you can see there's adequate amount of keratinized tissue, so we don't need to worry about it there. We then do our CT analysis. The CT analysis involves basically a virtual crown and then placement of the implants in the ideal position. So based on the analysis, we then have our soft tissue profile. So this is from the intraoral scan. Now we basically merge the intraoral scan with the CT scan, okay, which will give us our bone volume and our soft tissue volume. Looking at the defect, you can see here, we've got basically, vertically, it's not a big deal. I'm not too concerned vertically because here vertically, it's okay to have the implant a little bit more apical because it allows you to build emergence. So this was mainly my concern was a horizontal defect. And you can see the defect is horizontal, both on the buccal as well as the palatal portion. We merge all the digital data together. We basically use our intraoral scan or virtually planned digital crown, and we basically work backwards. So based on the crown here, we place our implant. Looking at the implant in the ideal position, we can see that we have a little bit of deficiency at the coronal portion of the ridge. If we look at it at a different angle, you can see from the occlusal point, we've got lack of volume on the palatal portion, as well as lack of volume on the buccal portion. So based on this, now we decide what our bone graft volume that we need is required. So here we then virtually create our digital bone graft volume. And this is basically the volume that we need. So if you look at it, we have basically a little bit of buccal volume, but a little bit of palatal volume, and if we can, some vertical volume as well. So it's sort of a graft that requires both buccal and palatal augmentation. So based on what I needed and the amount of both buccal and palatal bone volume, we wanted to do bone plates. So I originally had wanted the patient to do a Curie plate bone augmentation based on this sort of digital plan. So here we have our bone plates segmented and adjusted. So we see we have 2 plates on the facial, 1 plate on the palatal. And this was in my plan because I said, if I can create this sort of box, we should be able to ideally augment the bone quite easily and have enough bone for the ideal implant placement. Now the patient actually was against using his own autogenous bone. He didn't want to go to the external oblique ridge to harvest bones. So we had to make a little bit of a sort of recalculation. And I said, okay, well, if I can't use your own bone, then we can use a mixture of just the shavings of your own bone, which he didn't mind, and some allograft. And then we use allograft cortical plates. So I basically planned the case. Here we virtually plan our bone plates. You can see with the virtual placement of the implant, the crown, this is the volume and the position that we need for these bone plates. We then took all this and we 3D printed it. So here I not only 3D printed the implant in the ideal position, we have the bone as well as the teeth. So I can virtually see where our deficiencies are. So here, based off the 3D printed model, this gives me something in my hands because sometimes when I'm looking at this stuff virtually, it's easier to just have something in your hand. Some people just work better with it in my hands. So I usually like both virtual as well as a 3D printed model. So here you can see from the occlusal angle, basically that we had deficiency both buccal and lingually. Now, we also then 3D printed our little bone plates. Now, these were the bone plates that we virtually created to be able to get the volume that we needed. You can see here in the view, the bone plates are then positioned on the model, ideally how we like them. So based on this now, I plan my surgery. So I have basically, this is my virtual plan, which is now translated to a model plan with a 3D printed model. And now we take this and we do the surgery. So this is basically what I'm looking at with these plates. I want something that will hold this position giving me the volume I need to be able to get my implant in the ideally planned position. So we decided to use an allogenic bone graft because of the fact that he didn't want to use his own tissue. So we used an allograft block. Now the allograft block was trimmed to create these little plates. So these little bone plates that we made virtually and 3D printed were used as a guide to trim and adjust our bone allograft block. So I only needed a cortical plate, basically. So I wasn't using the entire block. Nowadays, I would use a cortical bone plate. When I did this case, the cortical bone plates were not available at this time. So I had to use a full allograft block and use the cortical portion of it. So here's our surgical case. You can see based on the surgery, we used a combination of, because we're using allograft blocks, I trimmed the allograft blocks into the bone plate pieces that I required based on the 3D printed model. We also then used PRF and sticky bone to fill the void with the allograft bone in and around the bone plate. And we covered it all up with PRF membranes, a collagen membrane, and closed it up. And you can see after about 5 months of re-entering, we have adequate bone volume for our implant placement, and then we provisionalize the site. So based on this, our virtual plan gave us the bone that we required. So this is also some of the digital implant planning. I'm just showing you because we can actually do an intraoral scan and a facial scan and render them together. So sometimes when we're creating our final crown or digital planning the case, we basically do a smile analysis with the patient and do a facial scan. And by putting all these layers together, creating our surgical guide for the implant placement, you can kind of get things looking better from an aesthetic point. And the virtual plan, this is for now at this point, it's more for an aesthetic case. I won't do a facial scan for something that is in the posterior because it doesn't help us. But this is more for the patient to just be able to see the tooth and their smile. It's more for things like the digital smile design where you want to see the different shapes of your veneers and crowns. So we started off like this, which was our initial pre-op defect. And this was our post-op based on our digital planning and the use of the allogenic bone plates through our virtual plan. So we got adequate volume. We can see both buccal and palatal volume is gained. And again, this is a case that we easily can augment the bone using the digital planning and 3D printing. Now, taking this step or this concept further, not only does it allow virtual planning and using 3D printed models, we can also harvest bone blocks through an approach using a surgical guide. Now, this was sort of, I have to give the pioneer of this technique, Luca Di Stavola, all the credit for this. Being in Canada, we could not gain access to the software and the company that he did. So when he first published this, that wasn't available for us in Canada. So I had to basically design and figure out my own way through it. We basically used the same concept of creating a surgical guide for implant. We basically used the same approach, but we created a surgical guide for a bone block harvest. And here I found that, based on accuracy, the best way was to have it tooth-borne, because if it can sit on the teeth, I know that it's accurate, it sits and it's stable, and it's a better way to confirm that all the reference points are marked and there's less deviation with where we make our cuts. So based on this again is made exactly the same way as the digital, as you'd make, an implant placement guide. The same concept is we're just sort of hacking the system and trying to modify to use it to do something else. Now, this guide is created in CT scan software, but then you take the guide and you export it into a software like Mesh Mixer, where you can do some adjustments and make your plane cuts to decide exactly where and how you're going to harvest the guide. And then this is 3D printed. This is our 3D printed model. You can see it's tooth-borne, it sits on the teeth, and it basically is quite accurate. We've done a few cases of this and they work well and they're quite easy to plan. So here's the actual surgery. You can see ridge is reflected, the guide is in place. I usually use a piezo to make my cuts. and there's our block removed. We use a Curie approach with some 2 micro screws. The gap is grafted with bone, covered with the collagen membrane. And there you can see after a couple of months of reentry, implant place, we have a nice ridge. So again, different application where we're using the 3D printing and planning to harvest a bone block. Okay, and these are the results. You can see again, it makes your life easier. Not to say that you can't do any of these surgeries without the digital planning, but it allows me to have everything pre-planned so that when I do the surgery, I just pop in the guide. It's safe because I know exactly where the nerve is, so I can, and I've planned my cut, so I know that if I cut here, there's no real thinking involved. I'm pretty comfortable. I make my cuts and harvest the bone quite fast. So it does improve on surgical time and efficiency as well as safety. This same concept again can be used for a chin harvest. Okay, so this is the same case. We did a bone block from the mental symphysis or the chin. Same concept here. Again, it's tooth borne. It sits in place. We have our little box where we make our plane cuts. This is the 3D models printed. You can see the actual guide for the harvest is there. These are again tooth-borne guides, so it sits on the teeth and it holds it in place, giving me a little bit more accuracy. Here's the guide inserted into the site and basically with piezo. Here actually my piezo machine, we didn't have it, it didn't work that day. And so I had to use a drill. So you can see the cuts are a little bit more coarse and larger, but again, it's guided by the actual surgical guide. Here's the block is removed. Now this is again a Curie approach, so I did not need to have a lot of bone. We just wanted the cortical plate. It's fixated in place. The gap is grafted with bone. And this is the post-op. After a couple of months, we re-enter the site. And this is nice, healthy, vital bone that we've got. So again, very simple, very easy to use way to approach these things. Now, my last case here is just going to discuss where this is going. Now, this is a case, it's not really implant related, but we basically tried some new technology and we're trying to see how we can modify this to use for implantology. Basically, we use augmented reality. So here we have a patient came in, they were referred because they had a cystic lesion. You can see in the CT scan the size of the lesion. And so when I was looking at this, I was realizing that how could a lesion like this just come out of nowhere? There must be some sort of reason or cause. So if you look at the little red arrows here, it looks like there's a little fragment of something that looks like either a supernumerary tooth or some sort of tooth fragment. So knowing all this, we basically were able to plan our case. And so through this, we 3D printed a digital model. Now the digital model allows me to access the cystic lesion in a more conservative approach. And so based on two things, knowing where that little tooth, supernumerary tooth was on the palatal side, as well as being able to access the entire cyst on the fascia, we were able to plan our surgery. Okay, now this is just the palatal side. You can see the hole in the bone. And then this is just our virtual planning. This is just the digitally planned 3D model. So this is just the computer segmentation. This again is what we 3D printed our actual bone model. And now you can see, so the lesion goes from the buccal to the palatal. Now, for access to be able to remove all the lining of the cyst, we had to access this, or it was planned to access it mainly from the buccal. But I also went into the palatal to be able to get that little supernumerary tooth. So here you can see buccal reflection both on the buccal portion as well as the palatal. Now, because I wanted to go from the buccal only for access to be able to adequately remove all the lining, because I thought palatally I would not have enough access. So we actually cut a window with the bone. I didn't discard the bone plate. I kept that window because we were going to basically reposition it back. So we cut a larger window on the buccal. We pull out the bone plate and we keep it. From the palatal portion, so here's the bone plate being removed on the buccal. Let's see, basically it's removed very gently so that we can keep it. You can see the lining of the cyst there. The cyst is all cleaned out, the lining is removed. But, we tried to be as conservative as possible. We did not want to, risk losing any vitality to the teeth. And from the palatal portion, we also accessed it and cleaned out and removed that little supernumerary tooth. So here's the site. Once the cyst was removed, I grafted the site and put the bone plate back in. Segment that we saw through the CT scan that shows basically that little root tip. So this is the cause of the cyst likely. So we remove this little supernumerary tooth, and now basically this was made easy through the digital planning and through being able to see this virtually. So what we also did with this case is we kind of took it a step further. We incorporated some augmented reality technology. And so this case I show because this is sort of where the future is going. There's a really good orthopedic surgeon out of Brazil that he works with a partner in Portugal that they've done a lot of this cool stuff with spine surgery and elbow and hand surgery. So this is basically using augmented reality. And what they can do, or what the technology allows, is to be able to bring the 3D models into your view in the room and have it like almost like a 3D floating model in the place. So this is just to show you what it's like. So you can see it's our virtually planned model. So this right now is just makes it easy because you don't have to actually look on a computer screen. You can bring the model into the actual surgery room, and you have to look at it through, special glasses to be able to have it rendered into your view. So it's basically, this is just a test. We're just moving it in the room. And you can change the model into different views. You can see it's sitting right above the chair. You can position it anywhere in your field of view that you want. And what's cool is not only do we have the model, but you'll see in a second how I also bring up the CT scan report and the slide. So right now, this technology just allows you to see this in real time while you're doing the surgery. Based on what your procedure is, it's kind of cool to be able to see it, just, have the patient in front of you. There's the CT scan again with the software. Just pull and position these where you want in the room. So literally you just turn your head and look, and you'll see the report just floating in the air. So this is sort of where we're going with augmented reality. And then the other cool thing is if you can combine this with dynamic navigation. I work with Navident, Claronav, and we're actually hopefully looking to test out and do some cool things with guided, real-time dynamic guided bone block harvesting. So again, digital planning is now going from where we're taking, the virtual planning. Right now, we're at the stage where we do the virtual planning and we 3D print the model, and that sort of interfaces us between the digital world and then the real time of the surgery. Now we're bringing in that model. Rather than 3D printing it, you can bring it in virtually through augmented reality. So there's the model on the table, and you can see the digital model floating in there. So this is the next step up. And then to take these and merge these, we'll have dynamic navigation through like technology like Navident and the other companies out there. So it's gonna get cooler in the future, and there's gonna be a lot of cool things, and I'm excited. So this is the end of my presentation, and we can answer some questions.
Thank you so much, Naheed. Actually, as I said at the beginning of it, it was absolutely new things for so many people. And as you said, it's not a routine now in many practices. But actually, I have many questions for me, and I actually want to know your opinion on that. First of all, you showed usage of microplates for your vertical augmentation, and I think that's a very, very good idea in doing that. I want to know, do you generally prefer to use such technique instead of using no matter allograft or xenograft or autograft plates? Because the main concept is to save the space and prevent the pressure of the flap to the augmented area. And these microplates do the same thing. So I want to know your experience on these.
So you're right. So, we tend to, remember Homely Wang's article on the past principles. And, so basically the most important thing for GBR, and I've noticed this because if you notice from my presentation, I'm not sticking to only one type of augmentation technique. I do all of them. You saw a little bit of allograft, autogenous bone, GBR, like everything. So what ties all this in together is following those principles of GBR. And so what the microplate does is it tents the space and maintains the volume. Now, you can do, so this case right here can be done with a Curie plate across. You can do with tenting screws. You can do with the microplate. They all serve the same exact purpose. They tent the space. So reality is there's many ways to augment a single case as long as you follow these rules. Now, what makes me choose one way or the other? Like, for example, a case like this, I could do a Curie plate, I could do tenting screws, I could do the microplate. But what ties them all together is the key thing that's important is space maintenance and volume maintenance. If you do those, no matter which technique you use, you'll get the same result, as you see here. So I think what leans me towards one or the other is the patient themselves. So some patients, are very timid. They're maybe a little bit scared. They don't want to harvest bone blocks. I may lean towards something like this. Or if, let's say, a patient is more at risk, where I think the tissue is not as good, or, there's higher chance of exposure, things like that, then again, I would lean to a more conservative, less complicated approach. Like, for example, a microplate is a very good approach because we get our tenting space, very minimal complication. If you have a wound exposure of the microplate, this is titanium. It's easy to manage. It's not like exposure of a PTFE membrane or a bone block. Those are, you also have a bigger problem. So I think this is more forgiving. I think if it's used correctly, it works really well with sticky bone, I find. No, you don't even have to use sticky bone. If you have a tacked membrane, then it takes the job of the sticky bone, because now you have a stabilized graft material with a tented space. So I think it's the concept that's important. It's not really the approach. Like I said, this can be done many ways. If you take into account, you have the concept and then you have the patient, which will allow you to choose which approach to use.
Exactly, because as exactly as you said, even in large horizontal defects, in large vertical defects, the point is there, and we want to maintain the space, and we want to reduce the risk of exposure. And when we can do these techniques with these mini meshes, mini plates, and even in horizontal dimension, we can place 2 or 3 strips of them, and then put a collagen membrane on top. So why not? Because as I remember, Joseph Shukroon and one more person also was a great fan of this by reducing the pressure from tissue to the recipient area. And you showed it exactly as it should be. And, when you say that there are different ways that we can augment bone, that's actually true. But if it's possible to go with the easiest, fastest way, so why not? Because that was one of the questions that I asked so many lecturers during Hot Seat, and I'm so glad that you presented it, because it's, as you said, easy, predictable, minimally invasive, and the complications, if happen, can be very easily managed. And my question on these mini plates, there are 2 types of them. Some of them are easily bendable. Some of them are more rigid. Which one do you prefer to use? Or is there any difference?
So you want one that you can bend to shape, but once it's bent, you want it to be rigid because you don't want it to move. So you'd have to have one that it's better to be able to still bend it, but once it's bent, it's still rigid. It doesn't move. So you have you have to bend it with pliers. But those are the good ones, because you just sometimes, if let's say I wanted to put another one on the like the buccal portion, and we want it to curve it to create buccal volume. So these are, I get these from KLS, okay, but any they're usually used for either oral surgery or orthopedic surgery. These plates, they come in different sizes and variations. Some of them are much larger. They call this one a micro one because it fits with 1 millimeter screws or 1.2 millimeter screws. And I find this size is ideal for alveolar reconstruction.
Yeah.
because the other ones sometimes are very thick and larger than these ones for, doing fracture reductions and things like that.
Yeah.
But
Sorry to.
like you said,
No,
go
no, no.
ahead.
Go ahead. Go ahead. Go ahead.
No, what I'm saying is, like you said, is it's mainly, creating that volume, this and that space maintenance. Like you can create almost like a cage with these microplates. You have one on the coronal portion on the ridge, some on the buccal and the palate, and you have basically now your cage that you now can fill with the bone graft. And as long as it's isolated with a membrane, it's like you get the same results with the bone block. In some cases, if I were to, for example, do a bone block in this case, it's already a complicated case because I'm doing a sinus lift, I'm doing bone blocks, it becomes much more complex. It takes longer when something like this could give me the similar results and much more easier on the patient. And so, sometimes I'm guilty of it too. We see all these cooler techniques and you want to do a full 3D bone block reconstruction. It looks cool. It looks like a nice case to present, but we always sometimes have to put the patient into account. And
Yeah.
to the sometimes, making it easier for them if you can get, the same results through something more simpler. It may not be as, sexy and cool as, a 3D bone block augmentation, but you get the same results.
Yeah. And as I noticed in this case, he used almost 100% allografts. Am I right?
Yeah. So I personally, when I augment bone for pre-implant placement, meaning that the implant is not there, I never use xenograft. I will use cortical allograft, and sometimes we'll mix it with autogenous shavings. But I don't like to use xenograft. The only time I'll use xenograft is after the implant is already in position and I'm not re-entering this site. This is just something that I found that allograft bone remodels faster. The quality is better. You don't see the granules. Like when you see this case, when we re-enter, you can see the quality of bone. It's good bone quality. It's solid. You don't see any granules or chips. So remodeling I found is much better. And if I want something that is a little bit longer lasting, then I use cortical allograft.
Yeah. Yeah. And in one of, I think it was in your next case, it was an anterior case that you did the guided surgery and placed allograft plates on the buccal
Yeah.
aspect. And you said that you chose a block and you tried to harvest, plates out of it. If I remember,
Yeah.
yeah, it was the same case.
Yeah.
So I know it's a totally different topic of discussion, but even in this case, do
Yeah.
you think that the same approach with those plates would have been a easier option or not?
Yeah, you know what? So you can do the plates. Yeah, you could, depending on how you position the plates, you could get, like technically I could not a plate, but let's say I put a tenting screw right down the middle
Yeah.
to get the height so I can get the peaks. For example, right here, if I put a tenting screw here and put I get the peak, and
Yeah.
then maybe one here to get it, and one let's say on the paddle to get the volume. Yes, you could do it. And with a tight collagen membrane where it holds it, you could do it with tenting screws easily, or even plates. Yeah.
So you find them comparable to each other.
Yeah. I mean, like I said, it's not so much it's the material that you use as well, but sometimes it's more important to have that space maintained.
Mm-hmm.
For me to be able to use the microplate here would be a little bit more challenging, especially to fixate it on the paddle and stuff. I found with the allograft plate, it's easier to just put in place and then put the screws in.
Yeah.
From a technique point, but the allograft plate, again, it's not coming from the patient. So from a morbidity point, the patient is okay whether I use microplate or this, it's the same to the patient.
Yeah.
But this sort of, I was thinking Kuri plate with autogenous bone, and because he didn't want to use autogenous bone, my mind just automatically said, okay, we'll try allograft bone. And I was concerned, with allograft that we get resorption and remodeling. So you can see here, I added sticky bone and PRF and just covered everything, all the screws and everything to get the bone, and we got good results. So, but yeah, like I said, this case can also be done with tenting screws or plates. It's the volume maintenance. Here, we got our volume maintenance by using the allograft plates.
And
But
regarding the fixation of these two plates,
yeah,
if I'm right, you put one plate in the buckle, one plate in the palatal, right?
yeah.
Or yeah. So do you prefer to screw buckle and palatal with one screw together, or you prefer palatal and buckle separately to be fixated?
So no, so what I do is the problem sometimes is when you do the parallel one separately, it goes sort of on an apical angle because it's hard to, remember this is inside the patient's mouth, so it's hard to even screw the screw in. So I prefer to do it from the buckle with one screw going through. So what I usually do is I'll screw the buckle plate with one screw. Then I'll put the paddle plate in, I'll clamp it with a hemostat or a bone block holder, and then I'll drill the second screw right through. Now, the other thing you can't see very well, but you can see the plate on the paddle here is shaped as well so that it wedges in. So it's also sort of almost gets stuck into the defect by wedging it in. And then that adds a little bit of fixation. The paddle flap is very thick, so it doesn't have mobility. So that with just the one screw going through is enough to stabilize. Usually once I've got it in place, I tap it with my periosteal elevator to make sure there's no mobility. And then with the sticky bone and all the wedging and the flap, it's held. But yeah, you want to make sure there's no micro motion at all.
No more commotion. And Naheed, I have another question regarding the guides for static crown lengthening that you show
Yeah.
one of your uh, own concepts, because there are many different shape of those guides. And one of the things that I want to ask, which I think maybe be a question for some of our audience, is that speaking of shaping the interproximal bone, as I remember, and if we can put it on the screen, in the interproximal bone, the shape of the guide was almost flat when we want to remove the bone. So I
Yeah.
want to know, do you use these guides to shape the buccal aspect and you do the interproximal separately? Or
So
the concept is to bring and make that interproximal bone in a flat shape?
So no, I don't. So this guide, I only use it to guide the amount of bone removal
Yeah.
light I need. I usually take it off and refine it afterwards.
Uh-huh.
Now, we were only increasing the length of the crown from a facial point, so I did not adjust the interproximal bone here. I just could have blended in. So I do not do any interproximal bone removal. It's almost like an aesthetic crown lengthening. So I don't even raise the palatal flap. This is papilla still here split. And so I adjust to just blend it in, but I do not remove the interproximal bone at all.
Yeah, I wanted to make that point clear.
Yeah,
Yeah. And my final comment, because your topic is very interesting and I know we can talk about it for hours, but as the time is limited and I'm pretty sure you're busy also. But regarding the topic of harvesting the ramus bone graft or plates with the
yeah.
guide you showed, and it was also a work by Luca. We saw some
Yeah.
presentation by him, and you showed it also beautifully. Um, my question is this. I know it's practical. I know it make the job much easier, faster, but I want to know your experience only. Did you find it easier to harvest the plate with these guides, or if a clinician is experienced in harvesting blocks from the ramus and just split it out of the mouth with discs,
Yeah.
it's going to be the same, or is it really necessary to go through those guides for harvesting the plate?
No. Okay. So very, very good question. So these guides do mainly one thing. They're beneficial when you're a beginner, when you have a little bit more fear of the nerve, or if you're very close to the nerve. It is a little bit more difficult to work with because it's bigger and you have to reflect the flap to allow this to seat in place, especially if you're going a little bit more distally. They become, I know Luca now does titanium guides, so he's thinned it out a little bit. It's not the resin like this. So as you get more comfortable harvesting, it is definitely easier to do it without the guide because there's less bulk and you can work in a smaller space. But as a beginner, when the fear is high and you're really nervous, then these guides serve a good purpose because then it takes away that concern. So I don't use the guides all the time. this was just more of a proof of concept to see, and we did it for a few cases, but I've become more comfortable. So now I just do it without the guide. But if I had a case that I wanted to get a larger graft and we were close to the nerve and I wanted to be more safe, then I would use it. So it does enhance the safety aspect, but sometimes it is cumbersome because it's such a large additional material in your little area, especially way in the back.
Yeah.
So it's fast if you're doing a simple, like for a chin block, it's very fast and easy. So that I would say the guide makes it fast. But in the ramus area or the external oblique ridge, where you have to squeeze this thing in and really open up the flap to get this in, it does tend to make things a little bit slightly slower if you're comfortable doing it without. But if you're as a beginner or you're not comfortable, it does work then, because then you just have to open the flap, get it in place, but then at least you're comfortable in making your osteotomies without slowly worrying about, oh, am I close to the nerve, and checking.
Yeah, great point. Great point. Naheed, I'm so happy that you accepted and you joined. I truly, truly enjoyed the presentation. Actually, it was a very hot topic and new concept, at least for many countries. Maybe they've not started yet to go this way, some beginners and amateurs, but thank you so much for sharing, for your time, for your patience. And it was a pleasure for me, and really looking forward to see you very soon. And stay safe, my friend.
Okay, thank you for having me. Take care.
Thank
You
you
too.
so much. Take care.
Okay. Maybe one day I'll get to see you in person somewhere.
Sure, absolutely. Looking forward to that.
Okay, thank you.
Thank you.